So, Dave Brown, well, the IVAN study came out very recently, and that was an interim result, so certainly the final result could be different than what we've heard so far from the IVAN study. Well, why don't you sort of highlight some of the differences between CAT and IVAN, and what were some of the results?
Sure. A lot of differences between CAT and IVAN. One, they had a 3-letter margin of inferiority as opposed to a 5-letter. This was because they had a smaller sample size. Second thing is their PRN involved a bunch more injections. They got 3 doses and then they went PRN, but if you ever had any leakage, you got 3 doses. And so if you had literally 2 recurrences, you had almost 9 or 10 injections. So the number of injections was higher. They also aggregated data between monthly Lucentis and monthly Avastin got aggregated together. PRN Lucentis and PRN Avastin got aggregated together. And then, yeah, so you got aggregated together the monthly and the PRN of each drug, and then individually. In other words, you never got the data on monthly Lucentis. There was no 4 curves. There were 4 curves, but they weren't 4 individual groups. This makes it a little hard to interpret the data. If, however, you look at the primary outcome, did Lucentis, was it non-inferior to Avastin? It didn't meet the non-inferiority margin by a very little amount. The p-value is 0.056, and if you do the math, literally 2 patients could have skewed it. 2 to 5 patients could have skewed it, where if they went the other way, Avastin would have been inferior, not non-inferior, but inferior to the drug. However, it met the primary endpoint of the interim analysis. The true analysis is 2 years. That's the proof of the pudding. They also showed, unlike CAT, they showed systemic anti-VEGF suppression done with a serum sample, not a plasma sample. And there's some controversy there because a lot of VEGF is located in platelets, but they showed more anti-VEGF suppression with bevacizumab as opposed to ranibizumab. Based on this, that was put in the European label as a reason to be cautious for using intravitreal Avastin. So primary outcome, same as CAT, Lucentis, Avastin, not inferior. However, unlike CAT, where the curves for monthly are almost on top of each other, and they truly look equivalent, this looks really, really close that Avastin almost lost.
Yeah, and I think that's a very important point, because if you just look at the press release, so to speak, of IVAN, you hear the 2 were equal. Yet, if you actually look at the curves, as you mentioned, the difference that was required to make it almost inferior, or not inferior, was a very small margin, and we'll see if what happens in the second year. And as you said, it was bunched. What do you think about, Carl, the PRN dosing regimen that they used in IVAN? Is that something that you're familiar with? Is it something you use?
Well, I don't use it because I think whenever there was an event, meaning there was fluid, they actually gave 3 injections. And so at least the way I think myself and many of my partners treat neovascular AMD, we do not mandate 3 injections when you get fluid necessarily. So clearly what they called their discontinuous treatment regimen, or PRN regimen, was much more aggressive. And I think that's one of the reasons, as David alluded to, more injections, better vision, same thing here. These patients just got more injections. And so I think that's why there was no change between the discontinuous and the continuous dosing. But it's not something that I think, at least I don't use that regimen.
The one finding that was very consistent between CAT and IVAN is the ability to dry out the retina. And both of these have shown that you do it better with ranibizumab than bevacizumab, and you obviously do it better with monthly versus PRN. Now, to date, whether we haven't seen hard data that makes a visual difference, I think most of us believe that in the long haul, that has to have some visual outcome that will be affected by having persistent fluid.